May I invite Dr. Sreenivas next?
Good evening, and I bring greetings from Ashramim's Kannur. So, I think this topic is meant for the junior surgeons, but I can't find many in the auditorium, so I'll talk to the seniors. So, contraindications for laparoscopy. So, the future of laparoscopy was grim way back in 1985 when first lap cholecystectomy was done. So everyone knows what was the greeting given by our own fraternity for that procedure that time. From there, with a better acceptance for the procedure across the world, the number of contraindications started diminishing. So the indications on the other side were improved. So this is an incomplete list. It was 20 years back in 2003 when I started doing laparoscopic surgeries. It's an endless list. So many of these things in this list are now switched over to actually indications, true indications for doing minimally invasive surgery. So what would have been a 20-minute presentation 20 years back is now crushed to an 8-minute presentation and pushed towards the end of the day is because of this. Now the surgeons consider there are no contraindications or no absolute contraindications for performing laparoscopic surgery. So when I was asked to talk about navigating, this is what came to my mind. So what is to be navigated, how to navigate contraindications. So yesterday we watched a lot many advanced lap surgeries being done with much ease and we were all thrilled. But mind you, all these surgeries were done in an ideal setup. They were done by expert surgeons. They were assisted by equally experienced surgeons. They were a very good team of anesthetists, good ancillary staff, and all equipments and gadgets at their disposal. But this won't be the situation when someone planned to start laparoscopic surgery at a peripheral setup, especially as a single-man unit. Laparoscopic surgery shouldn't be considered as a risk-free or a low-key affair. Complications do occur, and they occur when the surgeon exceeds the inherent limitations of minimally invasive surgery and when he fails to recognize his own limitations. So let us come to the limitations of minimally invasive surgery. What makes minimally invasive surgery different from open surgery is creation of pneumoperitoneum. So let us see what are the anatomical limitations. The most important prerequisite being creation of a pneumoperitoneum. What you need is a safe entry. So most of the time it will be difficult and sometimes impossible when it comes to reoperative abdominal surgery. When someone has previously placed an intraperitoneal mesh, when there is severe cirrhosis, great child C cirrhosis with portal hypertension, where you expect extensive abdominal wall varices. Then peritoneum, you need a good working space. So most of the time, the peritoneal space will be restricted in peritonitis, mechanical bowel obstruction with the grossly distended bowel loops, gravid uterus towards the third trimester, then gross organomegaly like a gross splenomegaly. So dissemination of cancer is again a concern. Though port site recurrence are rare, they are being reported even now. Then invasive cancers, the surgeon may not be able to adhere to the principles of oncologic principles of resection and might end up with a positive margin. Then tumor dissemination is a possibility, especially when you are dealing with some mucinous type of cancers. So the physiological limitations can affect any organ for that matter, mainly the pulmonary, where there is carbon dioxide retention, hypoventilation due to the distended abdomen. On the cardiac side, a reduced venous return and metabolic acidosis, and these two especially in situations like hemorrhage and shock. Then one concern is raised intracranial pressure because of extreme positioning. There is raised intra-abdominal pressure, and in patients with VP shunt, but the neurosurgeon says the VP shunt has got a very good valve, it never fails. So pregnancy, we talk about the safety of second trimester. The much debated maternal and fetal side effects, they are more of theoretical value, and the latest SAGES guideline says that irrespective of the trimester, you can perform laparoscopic surgery. There is no contraindication. But I still consider that third trimester it will be very difficult to perform surgery. So Coming to the altered physiology of pneumoperitoneum. So when there is an intra-abdominal pressure setting of 12 to 15 millimeter of mercury, every individual organ system becomes compromised, with the potential to increase the morbidity, especially in patients with pre-existing comorbidities. The effects on the cardiovascular system with the pneumoperitoneum, there is a cascade of events. There is compression of the aorta, there is compression of inferior vena cava, there is compression of the splanchnic system. Altogether, this reduces the cardiac output. And further raised intrathoracic pressure, further reduction in cardiac output. This is a thing which is going to bother the anesthetist. Most of the time, we will not be concerned about what is happening on the other side, at the head end of the table. So on the lungs, there is carbon dioxide retention, acidosis, raised intrathoracic pressure. Altogether, this leads to ventilation perfusion mismatch and hypoxia, especially in patients with a poor lung reserve and you maintain an extreme head down position. So what is the anesthetist has to say in this? So they say there are no absolute contraindications for doing laparoscopic surgery. That is in principle, but we know in practice it is different. They consider inexperienced surgeon as a contraindication, as we do consider anesthetist, inexperienced anesthetist as a big contraindication for doing advanced surgeries. The anesthetist is very much bothered about the cardiac and pulmonary disorders. With the added physiological effects of carbon dioxide, pneumoperitoneum, and extreme positioning, what they will feel is like the surgeon is rocking the boat. Is PAC a hurdle? Yes, especially for the junior surgeons. Your anesthetist will be senior, so PAC will be a hurdle. So how to overcome this? Do a proper pre-op evaluation to be done by the surgeon. The comorbidities has to be properly assessed. All pre-op consultation to be done before admission, and discuss with anesthesiologist, and think from the anesthetist side and explain all anesthesia risks to the patient beforehand, so that the patient is so primed that his facies will be like this when he goes for the PAC. From the cardiologist, they say absolute contraindication none, but this all pre-existing disease is going to be risky. Again, from the cardiac risk assessment, I will skip that. So there are no absolute contraindication for the pulmonologist as well. But patient with a poor lung reserve, active lung infection, hypercarbia, and respiratory failure, it is better not to do a laparoscopy. So let us see the list of contraindication currently. So any patient who is unable to tolerate the pneumoperitoneum, when there is an obvious indication for open surgery for some reason, uncorrected coagulopathy, hypercapnia, grossly distended abdomen, open wounds needing exploration, recent laparotomy especially done for peritonitis, and pre-existing cardiac and pulmonary, severe cardiac and pulmonary disorders. So who makes the decision? The surgeon has to make the decision. So he has to judge the patient properly. He has to assess all comorbidities, optimize the patient, do all necessary consultation, hold discussion with the pre-op consultants and your anesthetist, and have a team discussion, have a good team, and check your backup always when you are, especially when you are doing a surgery for the first time or when you are doing an advanced laparoscopic surgery. So if conversion is not a failure, the open surgery is also not. Open surgery is an equally good and effective way of treating the patient, and it's always the bailout when you end up in a complication in laparoscopy surgery. So to summarize, there are no absolute contraindications in modern era laparoscopy. Proper pre-op evaluation should prompt the surgeon when not to do minimally invasive surgery. A relative contraindication, along with a handicapped surgical team, is an absolute contraindication for performing advanced surgeries, and a handicapped team is an inexperienced surgeon, an untrained assistant, a non-cooperating anesthetist, and a malfunctioning equipment. So this is a handicapped team. So a safe surgery, everyone talks about safe surgery, it's a safe patient, and at the end of the day, a safe surgeon. So it's all teamwork. This is my team, thanks to my team, and thank you all, and thanks to the organizing committee as well. Thank you.
Thank you, Dr. Sreenivas. It's a very good presentation. As Dr. Sreenivas told, what we considered as contraindication for laparoscopic surgery some 10 to 15 years back are now indications for laparoscopy. And a popular statement that now there is only one contraindication for that is laparoscopic cesarean section.
I think that too will come.
But please consider all laparoscopic surgeries as major surgeries. There is no minor laparoscopic surgery. Any questions? Thank you.
Thank you.
Thank you, Dr. Sreenivas.
Thank you, sir.